I'm Dr. Jessica Reinick, and I am going to attempt to talk through fertility testing while I also attempt to curl my hair. So the first part of fertility testing isn't actually a test at all, and it is taking a full and complete medical history for the individual or the two individuals that are there for evaluation, because sometimes there's something in the medical history that makes me want to do more than the standard evaluation, and I want to know that from the beginning so I can talk about it all. But let's assume that we're doing the standard evaluation for a cis-het couple, because that will kind of include the majority of the testing that most individuals or pairs will be checking, and so it includes the information about it as well. So I start by saying there are four main areas that we look at when it comes to fertility testing, and three of those fall on the person with the ovaries, one of those fall on the person with the sperm. And that's not because male infertility is any more common than female infertility, but there's just more that we know. Also, we do pre-pregnancy testing at the same time. I'm so much worse at curling this side than the other side. It's kind of insane. So the first area that we need to look at is what's called ovarian reserve. And because people with ovaries are born with all of the eggs that they're going to have, we need to get a sense of where they are at on that pathway right now, because the number of eggs and the quality of eggs goes down over time. Now, some of that information is based on age, quality. However, we can do some tests called ovarian reserve testing that will look at the number of eggs. And I say there's no way to get an exact number actually, but we have some markers, one of them being a hormone called AMH or anti-Müllerian hormone, one of them being an ultrasound called an antral follicle count or AFC scan, where we take a look directly at the ovaries. And then we also get some indirect information by doing cycle day 3 baseline hormones, follicle stimulating hormone and estrogen, and those kind of tell me how your brain and ovaries are talking to each other, which is a little bit more of a functional look at your ovarian reserve. The next thing that we need to look at is anatomy, and so we need to make sure that the cavity of the uterus looks nice and healthy, that there's no polyps, fibroids, or scar tissue inside the cavity. We also want to make sure that the fallopian tubes are open, and the way that we do that is with a hysterosalpingogram or HSG, a HICOSI, which is a saline ultrasound that looks at the fallopian tubes, a hysteroscopy to look inside the cavity of the uterus, although it doesn't really reliably tell you anything about the tubes, and those are kind of the main tests that are done for that. These tests can be really uncomfortable for some, not all people, and so I always offer Valium for that. Finally, step number 3 for the female partner is going to be some other reproductive hormones like thyroid, prolactin, vitamin D. Those are things that can impact the process. And then some pre-pregnancy testing, as I said. So you want to make sure you're immune to chickenpox and rubella. You're going to do potentially genetic carrier screening depending on your history, or just expanded screening in general. And then also infectious disease testing. And then for the partner with the sperm, it's a semen analysis, which will look at the sperm motility, count, and morphology, among other things, and then also some blood work for infectious disease testing and the carrier screening.